Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário do Porto. Today, I will be discussing challenging lupus cases with Professors David Isenberg and Zahir Amoura from the Lupus Academy Steering Committee. David, Zahir, welcome, and thank you so much for joining us today.
Thank you, Raquel.
Let's dive on the first case. We will talk about a case of a young woman from mixed Caucasian, South Asian origin who presented at the age of 18 years old with arthritis and hair loss. The lab results revealed positive ANA in high titer dsDNA, positive anti-RNP, and lupus anticoagulant. She was treated with steroids and azathioprine and remained stable for 5 years. At the age of 23 years old, she went to see a GP for 7 cold blue fingers, and 5 hours later she collapsed, and several of her fingers were gangrenous. Lab confirmed microangiopathic hemolytic anemia with schizocytes and moderate low platelets, and catastrophic antiphospholipid syndrome was assumed. She was started with IV prostacyclin, steroids, cyclophosphamide, and heparin, and she improved. So let's just stop here for a bit. This happened in the 90s, not long after Ronald Ashford's first description of CAPS, catastrophic antiphospholipid syndrome. David, this was your patient, so you could find a specific trigger for this event. Do you want to comment what happened? Would you do it differently? That's almost 30 years going after this.
Yeah. Well, the story actually was, in a way, both unfortunate and even more dramatic than you've made it out. What happened was she went to see her general practitioner, and she was the last patient on a Saturday morning clinic. And I suspect the doctor was very keen to get away to do something else. And he looked at her fingers and said, well, just take some paracetamol. And as you've said, she then went home, but then collapsed and was found with, over this 5-hour period, to develop gangrene in many fingers. And we've recently reviewed, and actually just submitted for publication, a review of all the patients with CAPS that we've seen in a lupus cohort with around 850 patients, and we've seen 8 in about 40 years. So it's about 1%, and I think that figure has been replicated in other groups too. And as you imply, Raquel, we've always looked very hard to see if there was a trigger. And in 2 or 3 cases, there was, and it was infection. So infection clearly can be a trigger in this situation. But frustratingly, we've looked quite hard at these other patients. It really wasn't very clear why this particular awful event had happened at that particular time. These patients invariably have phospholipid antibodies, and I suspect if you're triple positive, it's more likely. But there's not a huge literature on this topic. There was a report from China of a slightly larger number of patients. One piece of good news, just I'll get the good news in first, is that we look to see, because all the patients have asked me over these years, will this come back? Once that episode, will it return? And in the main, it doesn't seem to return. It's like a one-off sort of series of unfortunate circumstances coming together as a one-off. It doesn't seem to come back. But I think the main stays of treatment remain the same. Intense vasodilatation in those sort of patients, we often give prostacyclin 24 hours a day if necessary for weeks at a time. We have assumed that there may well be some immunological component to this, and we've tended to use immunosuppression with these patients, and that would include things like steroids and cyclophosphamide on occasions. We've used plasma exchange in case there were factors within the circulation which were contributing to this, and then of course something like heparin, warfarin, whatever, you're going to have to work with your hematology colleagues to deal with this. But it is quite shocking, and we've seen a case quite recently, same sort of thing. A patient goes from being reasonably well, she was actually in hospital with pneumonia, which was one of these cases where there was a trigger, and overnight she developed gangrene in multiple fingers, multiple toes, the back of the heel. Why does this happen? We still don't know. I don't think we know.
Zahir, do you want to comment on your practice about CAPS? What do you do in the severe cases? Do you choose any other kind of medication?
Yes, I'd just like to add a comment on antibiotics. It depends on the clinical context. So we give antibiotics when there are clinical manifestations, suggestive of infections such as acute respiratory distress syndrome or multi-organ failure mimicking septic shock, keeping in mind that during CAPS, inflammatory markers, CRP, are often very elevated, even in the absence of infection. Maybe because during CAPS, there is a kind of cytokine storm, like in macrophage activating syndrome. So we also give antibiotics when the infectious risk is high, especially when we use cyclophosphamide. Maybe one comment about the use of heparin versus low molecular weight heparin. So low molecular weight heparin can be used for CAPS. I think it's a good treatment for CAPS, except in case of significant renal failure. So we use classic heparin when there is a significant risk of bleeding. I mean, when the platelet count is very low, because the half-life of classic heparin is very short. So when you stop heparin, there is no increased risk of bleeding.
When you use immunosuppression in these cases, in pretty severe cases, do you use also plasma exchange? Do you have any experience in using rituximab or even eculizumab? And this question is for both of you in these particular catastrophic cases.
We've used all three at different times, but it's very much, as they say in English, flying by the seat of your pants. The evidence base isn't really there. There just aren't enough numbers of patients to say with any degree of confidence what is going to happen. I think I've always thought where there were very high levels of autoantibodies, such as antibodies to DNA, then it's reasonable to try and get those down, and you can do that quite effectively with rituximab. We've done that. We have also used plasma exchange. We work with these patients very closely with our hematology colleagues. In my unit, we have some great colleagues who are interested in this area. But it's, there are no very clear-cut guidelines here. It's not that I'm aware of. I don't know whether you know.
Zahir, do you use rituximab?
Not so often, because as David said, the data on the use of monoclonal antibodies in CAPS, rituximab or eculizumab, are very scarce. So we use it as the last line of treatment when the CAPS is refractory, but we don't know really if this treatment is effective. So, well, just one word about plasma exchange. Yes. Or about cyclophosphamide. We use cyclophosphamide when the CAPS is occurring during SLE. Once it's a kind of primary CAPS, we don't use cyclophosphamide. We prefer IVIG, and we use plasma exchange when the CAPS is not responding to the first line of treatment. And the first line of treatment is anticoagulation, fully anticoagulation, plus high dose of steroids. But when the patient hemodynamic is not stable, we don't use plasma exchange in case of heart failure, for example.
Yes, just highlighting there's, of course, everyone that had one patient like this is always scared of coming the next. But when you say if it doesn't respond to the first line, we're talking about days, right? Not weeks, because this really kills people. But fortunately, she survived and improved.
Raquel, just one word about the evolution, the course of CAPS. A good marker of good prognosis, of good outcome, is the platelet count. When the platelet count is increasing. It's a good point. So as David said, the treatment of CAPS is sequential. First line, anticoagulation plus high dose of steroid, then IVIG or cyclophosphamide, and then plasma exchange or monoclonal antibodies.
Thank you for having that. She survived, yes, and 8 years after that, when she was 31, it looks like she was stable for this long. At 31, she presented with heavy proteinuria, and the kidney biopsy revealed class 4 nephritis. She was given IV cyclophosphamide with the NIH protocol, and for the following 6 years, between 32 and 38, she was treated with steroids and azathioprine. 2 years after stopping immunosuppressant, at 40, she had a renal relapse. Few glomeruli were in the biopsy, but still active nephritis, which improved with steroids and azathioprine. David, if this happened now, what would you prefer? Would you still do cyclophosphamide? Would you have any different option?
Okay, so I will answer that question, but I just want to make a couple of points because this is actually quite an interesting part of the history. So she developed her nephritis 13 years after the diagnosis, and that's pretty unusual, actually. We've been looking at this in our group of patients, and in my experience, and I'll be interested to hear what his experience has been, if you're going to get lupus nephritis, you tend to get it in the first 3 to 5 years. So it's very unusual for it to start more than 10 years after the diagnosis, but she was one of those patients, 13 years in. Now, the other point that I want to make that is, I think, very important is I'm often asked what are the causes of renal failure in patients, and undoubtedly for me the number one cause is failure to take the medication, and the number two reason is failure to take the medication, and the number three reason is the same. This patient was poorly compliant, I have to say that. And she was very sweet about it, but she said, I don't like steroids, they changed the shape of my face. And so how much treatment she was actually taking, I was always a little bit hesitant to answer that. But for whatever reason, maybe she did take just about enough. She did manage to improve the first time and the second time. And what would I do today? Well, there's two things that have changed. First of all, the introduction of mycophenolate has been a big plus. I think it's clearly more effective than azathioprine, certainly for getting patients into remission and probably also for keeping them in remission. So that's a choice. And as you will know very well, Raquel, I've been very influenced by the work of Liz Lightstone in London. Yeah. Who has used rituximab at the time of diagnosis. Now, steroids were introduced to the world in the winter of 1948-49, and they became the treatment of lupus and lupus nephritis in particular by the early 1950s. So until Liz Lightstone came along 10 years ago and said, we could treat this without using any steroids, which was quite a remarkable thing, really. Rituximab does, I think, have a place both in the treatment of lupus nephritis where other things have failed, but Liz has shown that you can actually, at the time of diagnosis, and these are biopsy probing cases, not if or but or maybe, these were the real things. She gave them 2 shots of rituximab followed by mycophenolate and hydroxychloroquine. And in our unit, we offer our patients a choice. We say you can have the conventional treatment, which is steroids and now mycophenolate and hydroxychloroquine, or we can give you, rituximab has been around 20 years plus now, we can give you rituximab. We'll follow it up with either methotrexate or mycophenolate or azathioprine. Pregnancy issues are important here because you can't take mycophenolate during pregnancy. You can take azathioprine during pregnancy. But yes, mycophenolate now plays a much, much bigger role than it did 25 years ago and didn't exist when this patient got sick.
Any comments, Zahir? What would you do? Today. Yes, today, of course.
If I had to treat the patient today, I would definitely really give MMF and certainly add belimumab. Just because we have to think on the long term when we treat patients with lupus nephritis. So MMF plus belimumab is a good option for me.
And fortunately, you do have MMF dosing to monitor compliance in your center. We don't have it spread, but in this erratic compliant patient, would you be concerned to give MMF without monitoring the levels?
It's a very good point. I think each time we have the compliance issue when we manage the patient, we prefer to use IV treatment, mainly cyclophosphamide during the induction phase. Keep in mind that when you use the AUC of mycophenolic acid, you don't really assess the compliance because you give MMF to the patient just before measuring the levels of blood MPA. So this is not a good assessment of the compliance. But the issue of compliance raised by David is very important in SLE. So
if the level comes back at 0, you probably got a pretty good indication.
Yes.
Not taking the drug.
Yeah, of course. Yeah, if the trough level is 0, you're sure the patient is not taking the drug. So.
Yes. So at the age of 41, 1 year after this, she went on holiday to the Democratic Republic of Congo and returned with heavy proteinuria, fever, and she felt unwell. She had a further renal biopsy, which showed the presence of tuberculosis. So I wasn't counting on that.
And I certainly wasn't.
And I do have a lot of questions about this. Do you think, Zahir, that she caught during an holiday TB, or what happened during this holiday? Was it just the high point of what was going on before going on holiday? What do you think, Zahir?
I don't think she got active tuberculosis during her travel to Congo, because we know that active tuberculosis is often the reactivation of an often old primary infection, and mainly because of the treatment. So my hypothesis is that tuberculosis promoted by the treatment has triggered the lupus flare, and we know that infections are triggers of lupus flare. So this is an hypothesis, and the final diagnosis was clearly surprising for me.
David, not an easy patient, of course, and this renal tuberculosis, of course, changes all the strategy for this patient after this. And what would you think that could just minimize this risk? And we are talking about a patient that started in the late 80s, 90s at lupus. So, but what do you think that in the current practice would change these? What would be your approach to these patients?
So the story of TB and lupus is quite interesting and clearly highly variable in terms of the numbers of patients who get lupus patients who get TB. I've just seen a report coming out of Indonesia where the level is extraordinarily high. It's I think 15%, really much higher than we've seen. Our figures are much lower than that. I think perhaps 1 to 2% of our patients have developed TB. So clearly, I think the part of the world that you live in is very, very important. I think Zahir makes very important observations about reactivation and infection triggering lupus flare. I think that's very important. Obviously, the in sense good thing about TB is that you could treat it. You could do something about it, and we did. She had the full anti-TB therapy for a couple of years, and she made a very, very good recovery. I think you have to be mindful of the fact that lupus patients are going to be more susceptible to all sorts of infections, and that depends partly because of the drugs that we treat them with, immunosuppressants in particular, and the disease itself is probably lends itself to encouraging infection. And I think TB has been a foe of mankind for thousands of years, and we do well to remember that it's there and it's around and it's certainly not been conquered. So we have to sort of be mindful of it. And I think it's one of those things that you just have to have at the back of your mind when a patient presents with a slightly odd set of symptoms or something that doesn't quite add up, doesn't quite make sense, that TB is a possibility. And I think the most important thing is to remember to think about it and to look for it.
Yes. And we know now that you share with us before the podcast that this patient unfortunately died from COVID.
Yes, it's very interesting. I'm sure, like the two of you as well, I've often been asked, well, what did a lot of lupus patients die with COVID? And in fact, they didn't in our experience. And I think there was a very simple, pragmatic reason for that. Virtually all of our lupus patients hid away. They stayed home. They did not go out. They didn't want to come to the hospital. And in fact, about 2 months into the pandemic, we had a shocking period. In about 2 weeks, we had 6 acute lupus admissions. Nothing to do with COVID, everything to do with active disease, active lupus. Our patients did not want to come to hospital because they were worried about getting COVID, because our hospital, like yours too, had hundreds of patients with COVID, and many dying, of course. And so the numbers of lupus patients in our group who died of COVID is very small, actually. I think it's around a half a dozen, maybe something like that only. And I'm sure it's just because they stayed clear until the vaccinations came in, then it became sort of safe to go out again. But it was tragic. She was one of the ones that sadly did die of COVID.
So pretty difficult case with lots of things going on and having to have a full mind, opened mind to manage it. So Let's see if the second case is going to be as difficult as this. A 40 years old African female was referred for fatigue, weight loss. She lost 5 kilos during the last month, fever, 39, and right paralumbar pain. The physical exam displayed bilateral malar rash. There was no joint pain. And the labs revealed pancytopenia, anemia with 8.2, leukopenia with 2,000, neutrophils under 1,000, lymphocytes 840, platelets just above 100, and creatinine was 47 millimoles per liter. The liver enzymes, ISAT and LAT, were 8 times the upper normal limit. Total bilirubin was 12. Hypoalbuminemia, 2.3. And the C-reactive protein was pretty high, 177. Procalcitonin was also high. Fasting triglycerides were in the 2 times upper normal limit with normal fibrinogen. And she also had positive ANA I titer, positive TSTNA, low C3, and this doesn't look good. The urine cultures were negative. She also had high proteinuria with 2.5 grams on a day. And the blood cultures were also negative. She did a kidney biopsy that showed lupus nephritis class 3, and the thoracoabdominal pelvic CT scan showed polyadenopathy, right and left, subclavicular, axillary, mediastinal lymph nodes, and there's the point, an abscess of the right psoas. It was aspirated, the abscess, and it displayed numerous Escherichia coli. So the patient was diagnosed with concomitant lupus flare with constitutional involvement, malar rash, and lupus nephritis, and the right abscess of the psoas. Zahir, this was your patient, and she was severely infected and with a severe lupus flare. Comments on this. How are you going to treat a patient that has both lupus flare and severe infection?
In this case, the patient had normal kidney function. This is very important because it means that you can wait before starting the immunosuppressive treatment. When I say wait, I mean 2 weeks, 3 weeks, just the time to control the infection. And this is exactly what we did. And we started with a wide spectrum antibiotics during 2 weeks. It's quite difficult to treat an abscess. Sometimes the antibiotics are not effective, but in this case, they were. And when we were sure that the abscess was controlled, we had decided to treat the patient with steroids plus immunosuppressant. And since the patient was of Afro-American origin, she had no compliance issue in her history. We gave her MMF, steroids plus antibiotics.
So here, could I ask, any idea why she developed the abscess in the psoas? Had she any trauma or any obvious reason why it was there?
No.
It was amazing, isn't it?
Yeah, it's not.
And at the beginning, the first hypothesis was TB abscess because in the psoas So we were surprised because it was a bacteria, and it was surprising. So
yeah.
So, and it looked like a pretty simple bacteria that would be easily treated. And as I said, she started on IV amoxicillin for 10 days and on hydroxychloroquine just to give her space to treat the infection before immunosuppression. But that didn't went pretty well. And on the 10th day of the antibiotics, the rash was better. The CT scan showed healing of the right abscess, but the fever returned. And she was dyspneic and confused. And the labs were not good also. So worsened cytopenias, higher CRP, higher liver enzymes values, blood and urine cultures were negative. and she had high procalcitonin. Fibrinogen was in the higher normal range. Triglycerides were high, and ferritin was 5,070/82, so high. And you are already thinking that this could be macrophage activation syndrome or hemophagocytic syndrome, as we're going to talk about it as HLH from now. And the bone marrow examination confirmed there were hemophagocytosis there. And if you calculate the H score at this point, it was high, with high probability of having hemophagocytic syndrome complicating this infection. The H score of Centered One is used for adults to calculate probability. It was not quite validated with patients that had mutations or something like that, but it's the only tool we do have on the current days to approach HLH in adults. So we kind of use it to know if the patients have high probability of having HLH just before the bone marrow. So, David, this is a severe complication of lupus, and it's not quite frequent.
Yes,
and it can happen during not controlled infection, and even more when you have an immunological disease on the background, and if it's not controlled. I think, in my mind at least, it puts me on the hypothesis if these patients should be treated differently to the infection and the disease activity from the beginning, or would it, if we were more aggressive on the beginning of the infection, knowing that she has a lupus flare, would it change? What is your experience? What do you think about it?
Okay, so firstly, perspective I think is important. This is a rare complication of lupus. Again, we've just had, quite by chance, as you know, Raquel, I work very closely with my colleague Jess Manson, who's quite an expert on this area. And so we looked at our cohort, 850 patients, we found 6 or 7 patients. It's about 1% or just 1%, under 1%. So this is not a common complication. So the vast majority of patients with lupus who get infections will not go on to develop this. And just as a slight side issue, if you see a patient with HLH and there is no overt cause, as is evident here, you have to know, as I'm sure you know, you have to look very, very hard for underlying malignancy, and very often hard to define lymphomas can be lurking and have to be sought quite hard on occasions. So in these sorts of patients, it's rare, but again, it's one of those things you have to be mindful of the possibility, and obviously measuring the ferritin level is very helpful here. And in therapeutic terms, in fact, I think the patient was about to get or was getting steroids. We tend to use IVIG as well as part of the first phase of immediate treatment. Second phase for us will be anakinra. I have no personal experience, but I know Jess Manson does, and I think you do too, of etoposide. So that's the general sequence that we've employed, but I'd be fascinated to hear what Zahir did with his patient.
Yes, what do you think about it? Knowing what happened, would you have changed from the beginning?
Yes, of course, I would have certainly started immunosuppressant earlier. If we look at macrophage activation syndrome during SLE, we have published a series of, it was a multicentric French series of 100 cases of macrophage activation syndrome during SLE, and 40% of the patients had documented associated infections.
Yes.
2/3 of the patients had ABV infection. The most common other viral infection was CMV, cytomegalovirus, and other patients had bacterial infections due to pathogens and also to mycobacteria, tuberculosis, but also other mycobacteria. And last, when you have MIS during SLE, you should always try to rule out lymphoma. Lymphoma is a complication of SLE and can also trigger MIS. Regarding the treatment, in SLE, we often use IV cyclophosphamide. because it allows the control of macrophage activation syndrome plus lupus flare. This is the first option for us, and in our series, it was quite effective. The second option is the one used by our hematologist colleague, and is etoposide. Etoposide it works very well in MIAS in general. We don't use rituximab. And we have no experience with anakinra or tocilizumab. So I think these drugs have been used mostly for MIAS during juvenile arthritis.
Yes.
One more comment about MIS during lupus. It's rare, as David said, but it's more frequent in childhood onset lupus.
Yeah.
So it's kind of different. We also found that in HLH, AMAS, both in lupus and other rheumatologic situations, that probably it can happen that we have more than one infectious trigger. So we do tend to exclude active EBV, even if when we have another infectious trigger. And I think that what you said before for this patient could not be excluded at this point. She could also have TB on that abscess and other infection, and it's not easy to have TB. TB often appears in HLH, whatever the cause, the immunological cause, and with other and aspergillus, and we really need to be thorough in the other infections exclusion and not think, okay, she has E. coli. E. coli. We're not going to find another infectious. We really need to be thorough. And I just wanted to comment the anakinra. So we are using more and more, but it's not treatment for the cause or the infection. We just use it to save the patient and have patient while we are trying to figure out what is going on beneath it. So anakinra is very good to support the patient from dysfunctions and lowering the cytokine storm, but it doesn't treat the underground. So when you start anakinra, you can't just sit and say, okay, now you're treating. No, you just need to go through all the rest of it. You are just keeping the patients alive for the rest of it. So these were both really difficult and highly lethal clinical situations that fortunately occurred rarely in lupus. And when we do have one patient like this, both the first one and the second one, we really need to get all the help we can, and we tend to discuss it with several other specialties. And even you two both know that when we have a difficult case like this, we just email to know your opinion. So we really need to have a network to discuss difficult cases. David and Zahir, thank you so much for joining me today and sharing your insights to our listeners. We hope these discussions have helped you gaining more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.